So I was asked to discuss cervical dystonia research. Obviously, it's a very, very broad topic, and it's going to be hard to implement everything in 30, 40 minutes. So I try my best. So I thought that what is the best way that I can present this? I came with this idea that put it in 3 categories. And one, about the research that has been done or is being done in understanding the mechanism of the disease. And I tell you why. You know, dystonia, generally speaking, and then also cervical dystonia, is very complex, under-recognized, and also with lack of, I can say, even understanding about the disease process and even the presentation. So you probably, some of you know that already, and some of you maybe not, that dystonia at the beginning was considered as like a psychiatric disorders. Especially for the cases with generalized dystonia, they consider those patients like you know, we have catatonia in schizophrenia, that the patients that they cannot move. And cervical, in dystonia, they basically consider that because patients that are mentally completely fine, very intelligent, and all of a sudden started to have like a twisting body parts, and they say, and then they couldn't find anything. I mean, nothing in examination is abnormal beside abnormal posture, and all the neurological tests are normal. Then they thought that, oh, this is the patient. For a long time, it used to be labeled as a psychiatric disorders or psychogenic movement disorders. And then basically the gene was discovered, and everybody understood that, oh no, that's actually, there are type of, basically subtype of the patients are genetically and some of them not. So just on my point is that even we don't even understand basically the semiology of the disease. Then we thought that, okay, perfect. We know that is a real neurological disorders and neck is turning. So let's just cut the muscle and things gonna get better. So it's very simple. And like Dr. Spencer here explained it to us, in the difficult cases still they do that, but they thought that at the beginning we can just resolve the issue. That's simple. They noticed that no, the neck, it seems that moved to other muscles and posture got, you know, even worse in some cases. So then we started to learn, no, it seems that coming from actually a brain. So you see that the step by step we learn it, but where is it coming from? So, but I want to admit that is still we don't know 100%. There are a lot of hypotheses behind that. It seems that it's coming from some deep nuclei in the brain, we call it basal ganglia, that they have abnormal discharges, and those discharges actually drive ahead to the wrong, you know, position. Because our brain is responsible the way that I have the sense of positioning my head and neck, and if there is an abnormal discharge, can deviate my neck to the wrong location. So this is actually one hypothesis. And it's not 100%. There are sometimes, interestingly, when you review the literature, you see a lot of even one study contradict the other one. One saying that there is a more activity in basal ganglia, the other one saying that actually is a decrease of activity. There are some suggesting that the problem is the cortex of the brain. You know that we have a brain cortex, and there are different areas of the cortex. So one of the hypotheses saying that there are like issues with, you know, we have a motor cortex, we have sensory cortex. They say there is a mismatch between those. You know, generally speaking, everything in life, if I behave some way, is due to what? I'm receiving information from outside. This is a cognitive neuroscience, right? So if I behave like, for example, I'm be happy because you guys make me happy, and then I react that way. So the motor system is like that too. It seems that there's some sensation that I feel, and then my motor system express itself. And there's a mismatch with that, so therefore again, it seems that neck goes there. So you see what I'm trying to at least give you a sense of it, that how still today, there are multiple hypotheses. I can go on and go on, just be lucky to cover that part. So therefore, I'm gonna show you just a couple of studies, just touch on them, because I cannot claim that I cover everything. A couple of things that at least you know that things are being done, and some scientists thinking to still discover or maybe uncover some mysteries about cervical dystonia. Then I want to touch in a couple of studies that medical treatment modalities. And when I say medical, doesn't mean that just only oral medication. I want to talk about oral medications, botulinum toxins, and deep brain stimulation. And Dr. Fry is going to cover completely that one. I just want to open up discussion for Dr. Fry, going to cover it completely. None of these treatment modalities that I say here are FDA approved except one. So therefore, I don't want you to walk away from here saying that, no, we weren't talking Las Vegas and said, no, that way of treatment, that way of rehabilitation, it's gonna, no. None of them are FDA approved except one, botulinum toxin, which I'm gonna discuss it. I just included that one in the research because it's just got approved, so therefore showing that at least our research in that field was, fruitful. And then at the end, I'm gonna touch on research and rehabilitation therapies as well. So as you see, because of time, it's gonna be quick, but at least give us a broad overview that being optimistic that things are being done. So one of the research is trying to discover the effect of botulinum toxin injection in our body and awareness regarding brain activity and head positioning. Okay, so as you see that title, how botulinum toxin injections in the neck affect body awareness and brain activity in people with cervical dystonia. So he's not trying to see the effect of botulinum toxin necessarily. Again, because I said this part of the discussion I have about our understanding better about cervical dystonia. So a little background about that. Why they are looking that way? Because patients with cervical dystonia often struggle with accurately sensing and positioning and movement of other body parts, not necessarily only their neck. So my neck is turning to the side, but it seems that when you look at in the research level, patients with cervical dystonia, they have some issues with even sense of positioning of other joints. That's very interesting. And now when I look at stuff like that, I understand that how important is that when we treat cervical dystonia, sometimes patients come and say that even my walking is better because they probably have a better sensation of how they are in the space and how they can basically adjust themselves. So it seems that this problem is because of some unusual activity in brain area that is important for planning and controlling movements. Again, remember I said that we believe that some area of the brain is abnormal discharge, so it seems that that's causing it. Specifically, it seems that those areas are overactive. So the increase of brain activity makes it hard for patients with cervical dystonia to correctly feel or interpret the movements, even the area that's not affected. So as I said, like a neck is turning, but even if you test them, they have some difficulty with positioning the rest movement. So that was based on the background. So therefore, in this study, the researchers, they thought we can explore if after injection of botulinum toxins and improving neck positioning, can we improve the sensation of the joint of other joints? Is it clear? So I have cervical dystonia, and they want to test me after injection if I can position my rest easier or not. This is exactly what they did. They tested in 15 patients with cervical dystonia and 15 with control group. And then they measured that how, when they asked patient to passively go up and down or active movement, passively means that somebody else is moving it, and or actively they can do it, compared to the control group and compared to before injection. So before injection, they test them, and then they treated them with botulinum toxin. At the same time, they measured brain activity using EEG, electroencephalogram, and which is a very invasive. You just put electrodes on the scalp and record the brain activities. That's the way we do for seizure disorders, for example. So what was the result? So they noticed that patients with CD, first of all, based on also the background, they thought that way, they have difficulty for positioning their joints other than the joint that have a dystonia, which is the cervical dystonia, for example. And second of all, they showed that their brain activity was also unusual, and after injection in their neck, their brain activity also returned to the normal. That's interesting. And patients also had a better sense and understanding of the movement. So, of course, the research done, and this is the result, then it's up to us to interpret the data. I personally do not believe that you injecting botulinum toxin, and botulinum toxin goes backward to the brain and manage the brain activity. It doesn't. It was a noise almost 10, 15 years ago, around I think 15 years ago, and somebody published something that, oh, botulinum toxin, when you inject it to the muscle and goes to the nerve, to the job done, you know, Dr. Torres, I'm sure that covered that area, that how botulinum toxin works. And yeah, that they showed a study that yes, it seems that after injection, retrogradely means that backward goes from nerve to brain. Nobody else replicated that. I think that was false, and we don't necessarily, right now, we do not believe that necessarily toxin has retrograde travel to the brain. So I don't think injection of my neck manage my brain activity through the effect of the toxin directly. I believe that probably the way that it is, when you improve my neck posture, then my brain, since my posture is better, receiving the normal, basically, or right information, now is able to process the data better, so therefore we get a better event brain activity. That's the way that I interpreted that. So the bottom line is that, you see, with all these interventions, they try to have a better understanding how brain manage the movements with patients with cervical dystonia. So another research, that's the title of that vibrotactile stimulation of neck induces head righting in people with cervical dystonia. So I tell you, what does it mean? So as a background, we know that patients with cervical dystonia, first I told you, they have a little problem with the positioning, about the sensing. Also, we know that a phenomenon, just antagonist, and today also I heard that Dr. Torres mentioned that, and it's a very interesting phenomenon actually, correct? So we touch area of the face or chin or back, and then my posture gets better. You don't hold it, you don't push it, just by touching. So very interesting phenomenon. So we know these, so based on that, based on the fact that also vibrotactile stimulation is a very gentle vibration that applies to the neck muscles, in this case, sternocleidomastoid, this muscle, and trapezius muscle, and temporarily improve the symptoms, okay? So with this, the researcher decided to test 67 patients with with cervical dystonia and apply that vibration therapy in their neck muscles for up to 45 minutes. And then the most participant, 85% of them experienced noticeable improvement of head alignment and improve the posture during the vibration when it was applied. And it's very gentle. So therefore, these findings suggested that neck vibration therapy could be an additional treatment for people with CD and add-on treatment with some people with dystonia. So again, I didn't present this here as a treatment modality. I presented this to tell you that how, again, our understanding about mechanism of the disease, that we apply something just with sensory stimulation and give us better understanding that how there is a relationship with the sensation and dystonic posture in cervical dystonia. So now I want to move to the treatment modality that I told you that I'm going to cover that part. And in treatment modality, the first one is oral medication. So definitely there is an unmet need in that field because it's not uncommon that I hear for the patients that when we offer them injection, they say, doctor, is this something I can just take and I don't have to come every time for injection? So it's a really ideal way. Unfortunately, our hands are tied now. There are multiple medications that we use that unfortunately they are not effective. They have side effects, and as I said, so there's nothing to be proud of to say, okay, I have this tablet, I give my patients and significantly get better. So therefore, there are some work on that field. There is one is going on right now that is a phase 2A randomized double-blind placebo-controlled study that assessed the safety, tolerability, and efficacy of MTR-601, which is a novel oral treatment in patients with cervical dystonia. So that study is going on right now. So development of this MTR-601 is based on some early research that showed that it can specifically relax certain muscles that involve in stiffness and spasms. And in non-human studies, it shows that it seems that improved some walking ability in some patients like cerebral palsy. So I'm sure that the first thing you want to ask me that what is this MTR-601, right? So MTR-601 is a new medication is being under study to help to reduce the stiffness and spasm in condition like cervical dystonia because this muscle spasm is involved. And its work is specifically in muscle protein, we call it myosin 2. And myosin is a protein that is involved in muscle contraction. So it seems that this medication is able to affect that protein, so therefore that's the way that effect is being felt by our patients. So MRT-601 is taken by mouth, and it's suggested that it can give non-invasive treatment and convenient, and it aims to reduce stiffness by relaxing and fast twitching muscles, that the muscles that usually we have in head and neck and other area, and hopefully improve cervical dystonia. So this is study at the phase, as I said, 2, and currently is, you can go to clinicaltrial.gov, find if there is any area close by your location that you can, if you are interested. So And then I want to just come one example about botulinum toxin injections. And as I said, it's not the medication that is under study right now. It is because just got approved, and I thought it's worth to mentioning. It's pretty new. And I believe Dr. Torres also mentioned it briefly about that. So it's the daxibotulinum toxin A, or we call it Daxify. So the main clinical trial was done and received FDA approval was on 301 patients with cervical dystonia, and they received that, and they showed that Daxify significantly improved symptoms of cervical dystonia compared to the placebo. So we had before other botulinum toxin, but what is important about this one? Interestingly, that all of us be kind of surprised was the fact that the mean of basically the benefit lasts about 24 weeks with the low dose of 125 units. And they had another arm of 250 units, and that one lasts for 20 weeks. So that's, even if it doesn't do it for everybody, because not everybody responded that drastically, but at least in the subgroup of patients, so that, as you see, for 24 weeks and 20 weeks, which is, this is, give us some hope that we are in the right direction. Because after a while now, there's a new toxin coming, and it seems that lasts longer. So the most common side effect was pain at the time of injection site. So I tell you in advance, yes, my patient's telling me that when you inject it, it has a burning sensation. But on the other hand, other side effects that we see, such as neck weakness, pain, and swallowing difficulties, actually were relatively uncommon compared to the trials was done in the past. So let's move on to section of rehabilitation. So I covered the two sessions of our understanding about research, the medical treatment, and now let's touch on rehabilitation. And then we have a QA. So first about exercise therapy. So when I wanted to cover exercise therapies, there are a lot of studies. Here I just put something as a summarizing everything. What is our view about exercise? Because there are multiple studies was done, or some of them are being done, to look at the effect of exercise by itself, effect of physical therapy, or effect of as an adjunct therapy with medication or with injection at the same time. So we all know about effect of exercise in well-being, and it's not something new. It was at least close to 30 years ago that somewhere in San Diego, the researcher injected mice with basically a chemical, was able to trace down newly born cells. So then they grouped the rats or mice in the cages to exercise. And then after a period of time, he sacrificed them, and they noticed that the animals that actually did exercise in cage, they developed newly born cells. And that was for the first time he showed that actually exercise can induce newly born cells in the brain. So at cellular level. So that's very fascinating. So that applies to a lot of neurological disorders these days, that because we have good science behind that. So why I said that, the reason I'm saying that effect of the exercise, of course, a lot of it can be due to improving our muscles, joints. However, I'm saying that because we know cervical dystonia, I said that at the beginning, I wanted to give you some foundation that coming from abnormal discharge from our brain, so maybe exercise also play a role that way as well, that improve well-being, improve brain health, and be able to give some extra benefit to our patients with cervical dystonia. So exercise therapy that uses specific movements, some equipments, and help to restore normal body functions such as movement and strength. And for people with cervical dystonia, exercise induces stretching, strengthening muscles exercise, aerobic exercises, and balancing training. So that's the part that's not central. So I said, the effect of exercise central by itself on the brain. However, the good therapist, that's the area, I know that we have another session later this afternoon that she's gonna cover nicely all, but I just wanna, unfortunately we don't have as many as good physical therapy like her that come and tell us, I wish you have to really train more and more people, because that's the area, in my opinion, that definitely is, we are being underutilized, because most of the physical therapists are not trained about that. Because I always tell my patients, the way that we inject botulinum toxin to manage this abnormal posture, what we do, we are weakening certain muscles to neck go back to the right position, right? We are weakening this muscle. We find out what muscle turn my head to the right. So with injection, make that muscle weak, so therefore neck back to normal. So what's another way that you can help that? You can strengthening the other side. So a lot of times I tell my patients, just put your hand here, turn, and count, like for 20, and relax. So you basically exercising the other side, helping your injection to bring back neck to the normal posture. So therefore, what I'm saying that there are a lot of studies that trying to show the efficacy of this concept at the research level. So exercise therapy is most effective when combined with botulinum toxin injection. So what does it mean? It means that everything I said doesn't mean that you can abandon your injection, any kind of therapy you receive. In my opinion, I totally agree that exercise is great, but is helping your another treatment modality. Don't expect with only exercise you'll be able to get a result that you were getting with botulinum toxin injection. However, it can reduce muscle spasm and potentially lower, even sometimes require botulinum toxin injection. So incorporating exercise therapy can enhance long-term treatment effects and reduce body tendency to become resistant even to botulinum toxins. So another modality that I want to talk about is TMS, which is transcranial magnetic stimulation. Again, I want to emphasize, especially here, that this is not, I told you at the beginning, but I want to emphasize again, this is not the FDA approved modality, especially I said for this one, because nowadays there are a lot of practices, they carry TMS. I want to make sure they don't come and say, hey, pay us like a $10,000 and you receive 20 sessions of TMS as a treatment modality. These are at the research level. Maybe next year I come here, I say, you know, everything I said, forget about it. That's approach, zero effect. Because that's at the research level, okay? And however, the foundation and background seems right and good. Because TMS, first of all, or transcranial magnetic stimulation, is non-invasive, is safe. It's basically like you go to dental office. It's a big chair, you sit, and technician come and there's a coil he put in your brain based on the mapping they do beginning to say which area they have to stimulate, and you don't even feel it that much. You maybe feel buzz a little bit, and that's it. And just for 10 minutes, sometimes 15 minutes, depend on protocol, you sit down and say, just go home. You think that they haven't done anything, basically. Just a coil they put, so, and that's it. So therefore, if really works, it's amazing because it's not painful. You don't have to shave your head or anything. You don't have to just, as I say, it's like you go dental office, takes 15 minutes. They say that come back again, depend on protocol, tomorrow or next week. Because, as I said, that treatment exists and is FDA approved for depression. So we know that is being offered. I just want you to make sure, be careful. somebody doesn't, tell you that also I'm covering it for cervical dystonia based on some research. That's only research. We don't know if 100% is effective or not. So what it targets, because when you do TMS, you have to know that based on your protocol, what area you are covering and stimulating. So they try to target cerebellum, because cerebellum is an area that we call it in the brain has an inhibition in other areas. Okay, so basically activity of cerebellar, so what the fibers coming out of cerebellum is basically controlling the other area of the brain. So they think that probably by affecting it, give it a little bit of more, like some medications that we use for decrease of tremor or relaxation, some of them work actually in the fibers in cerebellum. And so therefore, by that way, the hope is that reducing spasm and muscle tone disorders in cervical dystonia. And although botulinum toxin injection may be more effective in some patients, in some studies, again, TMS showed basically was effective in some, so then obviously has a fewer side effect, as I mentioned, compared to botulinum toxin injection, because TMS doesn't cause muscle weakness, doesn't cause pain, doesn't cause like a difficulty swallowing. So it may offer promising alternative improvement in the future, and if that's the case, can be a really good then treatment modality, at least add to your treatment that you're receiving. Like you're receiving, let's say, botulinum toxin, you tell your doctor, I feel, that's very common. My patient, they say, in the last 2 weeks, I'm really struggling. So maybe one day we can combine this with botulinum toxin injection. At the same time, it helps you to effect of maybe toxin lasts longer. This is maybe another way that research can be done. Do it a group of patients with only toxin injection, the other one with TMS, and we see if the TMS extending the efficacy. So anyway, there are some people that they try to apply it and look into it. So another treatment modality in the rehabilitation therapies is neuromuscular electrical stimulation. So neuromuscular electric stimulation is very non-invasive. You just send some electric signals to muscles that induce muscle contraction, relieving spasm by activating neural fibers. So some researchers with that, they say that can we actually do that and operate, because it operates by sensory organs of muscle and leading to the nervous system to get relaxed and reduce the spasms. So that's the foundation behind that. So some studies suggest that MES can provide rapid symptoms relief for CD, and with the short-term effectiveness superior even to botulinum toxin, but the short term though. Again, is it possible that eventually be used in combination even with injection? Maybe, because with CD there really are limited research and number of even patients, but shown some outcome when they target the muscles and spasticity after stroke as another treatment modalities. And at the end, the research about DBS, as I said, Dr. Fry gonna cover it completely, the whole session. When I was preparing for this, as a curiosity, I wanted to see what is really active. I just noticed that there are several locations try to look at that, because DBS, that DBS, we have more and more experience with the patients with Parkinson's disease, with patients with essential tremor. However, is being utilized for cervical dystonia for a long time. All of us, we have multiple patients with cervical dystonia and DBS as well. However, again, our understanding about it, because dystonia by itself is very complex, is limited. So we are still learning. We are learning that where we put the electrode on. So right now, majority of the places, they put it in GPI, which is the globus pallidus. However, I found there is this trial, they haven't started recruitment in China to comparing putting in globus pallidus versus another area that we use it for Parkinson disease is subthalamic nucleus. It's a small nucleus, below thalamus, and they want to see if the effect is different. So it's a very fascinating area. I'm sure that eventually going to be used even more in cervical dystonia as well, because in other fields with Parkinson, with essential tremors evolving, I remember the time that it was a bulky machine with the cord. We have to attach to the patient to even program them. Now I can sit in my office and patient is in Las Vegas, and I can program the patient that way, remotely. Now we have like a very, very small batteries. Used to be very, very big batteries. So it's really the area that fascinates, is evolving. The latest one, it came for Parkinson, that even communicating directly with brain, like means that is adjusting itself, because we send the electric signal to the brain, is stimulating the brain, is able to see if the brain activity changes and is able to adjust. It's a fascinating area, but Dr. Fry going to cover that. So I know that noon is your lunch time, so we have around 10 minutes for question and answer. Thank you very much.